Hi, dear friends. Welcome to my channel, Vital Health and Dental. Today, the topic we are going to cover is periodontal pocket depth. In this topic, we will be covering what is periodontal pocket and how it is measured. Periodontal pocket is pathologically deepened gingival sulcus. It is one of the most important clinical features of periodontal disease. Now, coming to periodontal pocket depth. Periodontal pocket is a very dynamic parameter. Periodontal pocket depth keeps on changing. There are basically two different types of pocket depth. One is the biological or histologic depth, and the other is the clinical or probing depth. Now, what is the difference between these two? First, I will tell you the definition, then I will explain it. What is the biologic depth or histologic depth? Biologic depth is the distance between the gingival margin and the base of gingival sulcular epithelium. That is the coronal boundary of junctional epithelium. Means in this diagram, just see here. This is enamel of the tooth, and here is the cementum, that is the root part. Now, on this root part, this portion is junctional epithelium. Between the two arrows, the area is the junction epithelium. Then this part lining the sulcus is sulcular epithelium. And this outer part showing red apex is the oral or outer epithelium. Now, what I told you is that what is biologic depth or histologic depth? Biologic depth is between the gingival margin. This is the gingival margin and the base of gingival sulcular epithelium. This is sulcular epithelium, and here is the base of the sulcular epithelium. So this will be biologic or histologic depth. Now, this is not practical. This biologic or histologic depth can only be seen or can only be detected in carefully prepared histological sections. This you cannot see it clinically, or this is only for the carefully prepared histologic sections. Now the other part is the probing depth. What is the probing depth? Probing depth is the distance between gingival margin to the base of the probable crevice. That is where the probe tip stops. Means up to the length or up to the depth where a probe can penetrate into a pocket is called as a probing depth. So it means that in an inflamed pocket, the periodontal pocket, the probe penetrates beyond the end of the junctional epithelium. I will explain it. Now, for these two diagrams, they clearly demonstrate that this is the histologic depth and this is the probing depth, histologic or the biologic depth. Biological depth is from gingival margin to the base of the gingival sulcular epithelium, and the probing depth is from gingival margin to the where the probe of the tip probe stops. Now coming to the up to which depth a probe can penetrate into a periodontal pocket depends upon the type of inflammation or the how much the what is the condition of the tissues. The biologic or histologic pocket depth is always shallower than the clinical or probing pocket depth. What does this mean? This means that in the biological pocket depth, the probe will be at the most coronal part of or most basic part of the sulcular epithelium. But in case of a clinical probing depth, it can go beyond the junctional epithelium into the connective tissue at the time of periodontitis. Now, the insertion of a probe to the bottom of the pocket elicits bleeding if the gingiva is inflamed and if the pocket epithelium is atrophic or ulcerated. Non-inflamed sites, they rarely bleed. Bleeding on probing is an earlier sign of inflammation than the color changes. This all of us we know. Now, probing depth is generally less than 3 mm in gingival health, but in case of inflammation, it can be more than 3 mm. Armitage and colleagues in their landmark study, they conducted experiments in beagle dogs with 25 grams of force, and they concluded that in case of healthy gingiva, the probe penetrated junctional epithelium to about two-thirds of its length. Means when the gingiva is healthy, when there are no clinical signs of inflammation, the probe, it went up till the depth of two-thirds of the length of the junctional epithelium. In case of gingivitis, the same probe with 25 gram of force, it stopped 0.1 mm short of the apical end of the junctional epithelium. But when there was periodontitis, the same probe with same force consistently went past the most apical cells of the junctional epithelium, and it went into the connective tissue compartment. It means that as the inflammation increases, the probe tip penetration goes deep into the connective tissue. Reason is very simple. The reason is that when the gingiva is healthy, connective tissue is more fibrous, and the fibers of the connective tissue, they resist the penetration of the probe. So in case of healthy gingiva, the probe tip is stopped in the junctional epithelium only. While in case of gingivitis, when there is inflammation of the gingiva, the probe penetrates up till 0.1 mm short of the apical end of the junctional epithelium. But when there is inflammation of the periodontium, when the connective tissue is inflamed, when the connective tissue fibers are being destroyed, then the tissue cannot offer more resistance. So the probe tip goes consistently past to the most apical cells of the junctional epithelium, and it goes into the connective tissue compartment. Human periodontal pockets, probe tip penetrates until it finds the most coronal intact fibers of the connective tissue attachment. Now, what are the factors which affect the probing? In probing, the most important factors are size of the probe, probing force which is being used, and direction of probing. Now, what should be the size of the probe? It is very common thing that if there will be a thick probe tip, then it will not go into the deeper pockets which are narrower. So the size of the probe should be standardized. In normal cases, less than 1 millimeter size of the probe is standardized and it is used. Now is the direction of probing. Direction of probing is very important, because if we cannot replicate or duplicate the direction of probing, then we will not be able to probe from the same direction, which will lead to an error in probing. For this direction of probing to remain constant, the formation of stents is done. Stent it can be made a custom made acrylic stent from which a marking can be made, and in this marking only the probe will be inserted, so that when the next time when patient comes and we do the probing, we can actually replicate the probing direction. Probing pressure is very important. We will discuss it later. Then comes the convexity of the crowns, restorations, and subgingival calculus. I will show you in the next slide. And condition of the gingival tissues. As I already explained it to you, that if the condition of the tissues is edematous, then the probe will go deeper into the tissues as compared to when the condition is fibrotic. Done. Now, what are the landmarks which are to be considered while doing probing? It is crest of the gingival margin, then cemento-enamel junction, then it is base of the probable sulcus, alveolar crest, and mucogingival junction. See, in this, how to do probing. A probe is inserted from one direction, and then it is actually walked circumferentially around the tooth, and the deepest part on this probing is noted. To test for bleeding after probing, the probe is carefully introduced to the bottom of the pocket and then gently moved laterally along the pocket wall. Sometimes bleeding appears immediately after the removal of the probe, while other times it may be delayed for a few seconds. So it is better for the clinician to recheck for bleeding 30 to 60 seconds after probing. Bleeding on probing is not a good predictor of progressive attachment loss, but if there is absence of bleeding on probing, then it is an excellent predictor of periodontal stability. Now coming to probing force, maximum force of 0.75 Newton. 0.75 Newton is generally well tolerated and it is an accurate force. 1 Newton is approximately around 102 grams. Forces up to 30 gram, when the forces are applied up to 30 grams, tip of the probe remains in the junctional epithelium. But when these forces, they exceed over 50 gram, then the probe, it crosses junctional epithelium, it goes through connective tissue and it reaches bone level. Now, when evaluating differences in PPD before and after treatment, the reduction in probing penetration may be a result of reduced inflammatory response rather than a gain in attachment level. This means, this is an important point, I'm going to explain it. It means that, like when the patient came on the first visit and you noted down a probing pocket depth of 7 mm, let's for example, that done. And after treatment, now the probing pocket depth has reduced to 5 mm. Now the question is whether that 2 mm of probing pocket depth which decreased is actually a gain or it is the result of reduced inflammatory response. Means when there was very much inflammatory response, then the probe tip went past from junctional epithelium into the connective tissue. But now the inflammation has subsided. Now the tissues, they have become more fibrous. So they are giving more resistance to the tissues. Done. Probe angulation, I have already told you that registration stents, they are used to maintain the same direction. Now see in this diagram. This is about I told you about the convexity of the crown, then overhang of the restorations. If there is wrong probing direction of the probe, then the probing depth which will be measured will be wrong. See, this is the depth of the pocket, but here as we have inserted the probe not parallel to the long axis of the tooth and it will not reach up to the full depth. Here the crown is very convex and there is calculus present. Due to the presence of this calculus, we will not be able to measure the actual pocket depth on the first visit. After initial visit, when the scaling and root planing is completed, then the actual depth of the periodontal pocket can be measured. In case of the overhang of the restoration, again the probe cannot penetrate up till the full depth. Now, inter-examiner probing error. There is probing depth discrepancies between examiners which are reported to be as much as 2.1 millimeter. That is average of 1.5 mm inter-examiner error is noted. Why this is important? This is important in research purposes. This is important when patient comes on repeated visits and the examiners who take the probing pocket depth, they are different. Then you have to take into account this much of the inter-examiner probing error. Now, when to probe? The probing is done for diagnosis, then for monitoring the course of the treatment, and then initial probing, and then for maintenance. As I told you in the diagram, that initial probing may be hampered by heavy calculus and inflammation. That inflammation might lead to bleeding on probing, which can actually cause discomfort and pain to the patient while probing. So initial probing depth might not be very accurate. To do the proper probing, we have to wait till the scaling and oral prophylaxis is completed. Now see, what are the important things which we have taken into we have to taken into account? See, here is the presence of a crater. Done. If we will use the probe or if we will insert the probe in this direction, this will not reach the maximum depth of the crater and we will not come to know about the actual depth. So the probe is to be angulated from both buccal and lingual directions towards the center of the crater so that actual depth can be monitored. Now, detection of pockets can only be done by a periodontal probe, by walking a periodontal probe into the periodontal pocket. This is the only accurate method of detecting and measuring the pockets. This is not detected by radiographic examination as pocket is a soft tissue change and you cannot see a pocket on a radiograph. Radiographs will show you area of bone loss in which pockets can be suspected, but if there is recession, then bone loss will not correspond to the pocket depth. Okay, X-rays will not show you the pocket presence or pocket depth, and X-rays cannot even tell you the difference before and after pocket elimination. Now, probing technique. Probe should be inserted parallel to the vertical axis of the tooth and walked circumferentially around each tooth so that it can detect the areas of deepest penetration. Done. In the interdental craters, probe should be placed obliquely from both facial and lingual surfaces to explore the deepest point of pocket located beneath the contact point. And the last is furcation involvement. In furcation involvement, you have to take into care both the vertical and the horizontal axis of the furcation. The vertical is to be noted with the normal probes, while the angulated part can be used with the curved probes like neighbor's probe. Done. This covers all of the probing, what is probing depth, how the probing is done, what are the factors which are taken into care, what is the probing force, and what are the things taken into consideration. Thorough probing of the gingival crevice and the surrounding tissue provides a wealth of valuable information beyond probing depth and bleeding on probing that is essential to the diagnosis and treatment of periodontal disease. Last but not the least, when not to probe, we have to take into care that in the presence of severe gingival inflammation, accurate probing depth measurement is difficult because of the pain, discomfort, and bleeding. So, when anesthesia has been administered before root instrumentation occurs, pockets should be thoroughly probed for subgingival calculus, any root surface concavities, any furcation involvements, and probing pocket depths. In the presence of overt and obvious periodontal disease, it may be best to delay accurate probing depth measurements until the scaling and root planing appointment when the tissue is anesthetized. Thank you.